Hello everyone, my name is Oluwatoyin Iberonke. I am a fourth-year medical student at Oakland University William Beaumont School of Medicine. My medically challenging case is on pressure-induced necrosis management, a challenging case report. This is on a 70-year-old female we presented to our emergency department with a perforated sigmoid volvulus. She immediately underwent an exploratory laparotomy and was transferred to the intensive care unit with a wound vac placed. A few days post-operatively, she unfortunately developed an infection in her abdomen which required serial abdominal washouts. Around post-op day 14, she was found to have developed areas of pressure necrosis on her sacrum, left popliteal fold, and ischium. She was evaluated by wound care, who recommended that we use Mepilex for padding, and we actually do dressing changes to reduce friction and shearing. We will evaluate the causes and management of pressure necrosis. Pressure necrosis can be referred to as pressure ulcers or bed sores or decubitus ulcers, amongst other things. The types of pressure necrosis varies from stage 1 to stage 6. Stage 1 being non-blanchable erythema, skin is still intact, and stage 6 being deep tissue injury with unknown level of tissue injured below the skin but having an intact skin. The risk factors for developing pressure necrosis can either be intrinsic or extrinsic or both. Intrinsic factors include diabetes, smoking, malnutrition, obesity, altered consciousness, decreased or altered sensation. Extrinsic factors include moisture, immobility, shear forces, friction, poorly fitted medical devices, or prolonged contact with hard surfaces. For my patient, I believe our extrinsic factors were prolonged contact with hard surfaces and immobility, and our intrinsic factors included diabetes, obesity, and altered consciousness. The algorithm for risk evaluation and management of pressure-induced necrosis includes first, preoperative and or pre-admission evaluation of patients. We can determine high-risk patients using scales like the Norton scale or the Braden scales. When we find out if patients are high risk or low risk, we technically manage them the same way. We develop a plan for repositioning, and this varies for each individual, and this should include general medical conditions and goal of care. We also need to consider lifting instead of dragging patients during repositioning to reduce friction and shears on the skin. We want to use gel pads at pressure points for immobilized patients because this reduces prolonged contacts with hard surfaces. And also remember that when patients are undergoing surgeries for more than 4 hours, we want to use gel pads for them as well. We also need to ensure that they have proper fitting of medical devices when needed. Report every risk factor assessment with any changes in mobility or medical conditions, and we need to repeat these assessments every time the patients undergo any changes as well. We need to ensure that we document repositioning and regular skin assessments, and make sure to note that this is very important for determining early signs of pressure necrosis formation. In conclusion, patient repositioning is an important aspect of patient care and should be incorporated into the anesthesiologist's care plan. Certain conditions can cause a patient's risk of developing pressure necrosis, leading to an increased risk of patient morbidity and mortality. Pressure necrosis is a complication that can easily be avoided with adequate preparation and attention to patient positioning. Thank you.